Well, good day, everybody, and welcome to the program on home health business, critical regulation, and policy, focused on technology and in particular telehealth. I'm Bill Dombi. I'm the president of the National Association for Home Care and Hospice based in Washington, D.C. And we have a couple of really good experts with us today to talk about telehealth and where it sits in home care, and hospice services. First, we have Carol Yarbrough. She is the Business Operations Manager for Telehealth Resources at the University of California in San Francisco. Welcome, Carol. And along with her, we have Dan Lowenstein. Dan is the Vice President for Policy at one of the largest home health agency, hospices, and home care companies in the country, the Visiting Nurse Service of New York. Thank you, Dan, also for joining us.
Thank you.
So today what we're going to do is explore a number of things, but we kind of need to set a bit of context first because our audience may have a varying degree of knowledge of what type of telehealth services are provided in the home care setting by home health agencies and hospices. So Carol, can you give us an idea of the nature and depth of telehealth services that are provided within a home health care and hospice type environment?
Well, I'll go with the home health care first. Generally, the telehealth that can be provided can now be written into the plan of care for the service. It's not necessarily billed separately. And so as long as it's in the plan of care, the telehealth supervision and, check-ins can be done via telehealth at varying intervals. Now, in terms of, and the same goes with remote physiological monitoring for home health as well. And that's something people are very interested in lately. For hospice, telehealth is a great tool as long as you get added to the panel of doctors or panel of providers that can see that patient during the hospice time. Telehealth is very, it's a great tool. You see the patients in their home or wherever they're, residing at the time. And it provides a continuity of care for perhaps an oncologist who had been following them or someone else. So it's really beneficial. And as long as you get added or, included in that plan of care team, these services are reimbursable.
Well, thanks, Carol. Dan, Visiting Nurse Service of New York, has it adopted telehealth as part of its clinical services to its patient population?
We have adopted telehealth as part of that. We do use remote patient monitoring, and we do telehealth visits. There is we really started in earnest, or it really accelerated during the height of the pandemic in New York last year. We found it to be very beneficial, particularly when it came to preserving what was a very preserving the workforce and making sure that it was really targeted there, because we were having a tough time with the workforce, and we still are, and I know home care agencies around the country are. It was also very important to ensuring that people had access to care. This is a time, and this still exists, where you had a lot of concern with people entering the home and making sure that people still got their services while without the fear of infection was very important. And lastly, we found that it was very people liked it. Satisfaction was high for the use of telehealth. There are protocols. It's, we have protocols about what we do use it for and what we don't use it for. It had to be something that the patient was bought into. They had to be self-directing. There's a number of things that we put in place there, but overall, it's a very valuable tool.
So from what I can tell, clinical services plus, as Carol mentioned, some of the administrative supportive services and supervising staff in the home care setting. Any feel for the degree to which telehealth has been widespread in its adoption by home health care or hospice providers of services? Carol?
Well, generally in San Francisco, in terms of what I know about from our hospice providers, that pretty much went to 100% in March of 2020. Volume wise, I couldn't quote those definitively, but in terms of the population, it was 100%. And currently we're back at around 80-20, 75-25, with more leaning towards in-person visits, and maybe around 25% telehealth, which I think is kind of a statistic everyone's kind of experiencing right now.
We at the National Association have done some surveying around this, and we find that 60 to 70% of providers have actually adopted telehealth, and it fluctuates, as you say, in San Francisco with the degree to which it's used in comparison to in-person visits. How about in the New York area, Dan?
Not sure if I have the data on that. I do know that one of the areas that really we're constrained by is the structure of the benefit, though. The way that Medicare reimburses for care in the home is by visits, and if you don't have enough in-person visits, you don't qualify for a payment, for a monthly period payment, and that's of a disincentive to do more telehealth. So that is, there's there's competing issues there that make it, probably more challenging and would make it less adaptable than it should be.
So Medicare is a bit antiquated the way it deals with home health in terms of then recognizing the cost and reimbursing for the service. Carol, how about Medicare Advantage in your area? Are they paying for telehealth services for that Medicare patient? Are you having experiences there?
In generally, Medicare will cover everything or Medicare Advantage will cover everything that Medicare covers. So they tend to follow the same policies. They are allowed, however, to cover more services than CMS allows Medicare. So certainly if it's in the population's interest within that payment area or that coverage area, they will amend the policy to reflect what is going on currently with the PHE. They'll amend their policies to reflect, the better treatment for the greater good. I do think, however, though, in terms of what Dan was saying about however many visits, and then you have to intersperse those with the telehealth visits, and certainly I believe it's the RN supervision for these visits as well, or like the supervisor over, the RNs that go, a certain percentage can only be done via telehealth. So I think this has more to do with regulatory than payer incentives. So hopefully, with any kind of upcoming regulations that are being considered by Congress, that this could change.
Yeah, you mentioned something very important, which is, Medicare Advantage plans have some flexibility. We have actually seen some plans pay for the telehealth virtual visits, not all of them, but it's within their discretion to decide on whether to pay for it. Unlike, as Dan said, traditional Medicare doesn't recognize it within its payment model, creating a bit of a roadblock to the delivery of those services. Dan, Medicaid home care is very big in the state of New York. Where does telehealth fit into Medicaid there?
Well, first of all, and to pick up on what you and Carol were saying, yes, Medicare Advantage is more flexible in its payment and will allow more innovation in there. Medicaid, first of all, Medicaid is a smaller part. In New York, we are a managed care state when it comes to Medicaid. That means that it's essentially the managed care plans have limited flexibility in what they can do, and generally they have not been tied to a per visit type of in-person per visit arrangement. That's the majority of Medicaid is, so it's just like any other managed care plan. You'd have, in Medicaid managed care, it could be a MA plan by the same sponsor, could be a commercial plan by the same sponsor. So in that sense, it's been good. There's a smaller Medicaid a smaller Medicaid fee-for-service component. Just recently was updated to reflect kind of the cost of delivering care, which is a very good thing. And generally they are, I think they're getting there when it comes to the use of telehealth.
Okay, and Caroline, California, where you operate, where does Medi-Cal, that's the name of their program there for Medicaid in the state, do they cover telehealth visits?
Yeah, 100%. No matter where the patient is located or the beneficiary. In terms of home health, I have to admit to not being quite so up on the Medicaid requirements for that for this area. I did want to say though, in terms of managed care, we do have still some fee-for-service Medi-Cal, and by, I believe, 2022, they plan on going fully over to managed care. And there's been a lot of meetings and a lot of contract ROIs approaching that. So it'll be interesting to see what more services can be added once there are more capitated type plans managing the population. I'm sure more telehealth will come out of it.
Let's shift a little bit to the value that telehealth may bring or not bring. Is it helping at all with staff shortages that we keep hearing are occurring with nurses, therapists, and home care aides? Is it a tool to be used for filling in that gap in terms of the staff needs that are there? Dan, how about that?
Sure, I can take that. Yeah. It really is. I mean, it does not discount the need for in-person care, and particularly in some circumstances. And that is, I mean, there's, and we actually developed a set of services that, we believe, could be delivered via telehealth, and those that, really they could not. They needed, an in-person person to deliver. Virtual visits could include, pain management, medication management, safety instructions, hospital avoidance tactics, things where there's conversation there. But start of care admissions really, we believe, should happen in the home. I mean, the home is the place where, there's a reason for the home health benefit, and that it is the home is a special place. This is, the nurse that is in the home will get a sense of that person's environment, any risks involved, that, you could try to emulate it via telehealth, but really, you get a stronger sense of that in the home. Now, you were asking about some of the, I think I went off topic a little bit there, but.
Well, I think you did cover it, but specifically on staff shortages. New York and other places have fewer nurses than they need in all healthcare settings. Is this helping to address that?
It does, and it can, and I think it has greater potential. And I want to talk about that particularly in hard to serve communities. There are a lot of communities that we're in. It's hard to find staff to go into certain communities, and that's unfortunate, but it's true. And oftentimes there's the issue of patient refusal. Patients don't want to have somebody in the home, and for whatever reason that might be, but they still need care. And I think that there's something there that would that helps to both provide the access of care that people need, and provide, as well as to provide, allow staff to, engage with the patient, even though they're not in the home. Now, that requires a use of technology that some folks don't have. I mean, there's a lot of education that could be, so I think that we're a long way from that being a universal access concept, but it is something I think that's worth exploring.
Now, I follow up on that just a little bit. Does telehealth at all fit in as a value to address issues of health equity? It
can. If people have they need an internet connection, they need a device, could be their thanks to the PHE, it could be your home phone or computer. If you are assuming that everybody has that, that is one thing. Not everybody does, but it can help address issues of access that in both in rural and urban and suburban communities that that are hard to address by having somebody on the ground going into somebody's community and home.
Carol, I remember when telehealth was kind of first introduced into home healthcare back in the 90s, maybe even in the 80s, but mostly my experience was then in the 90s. And it was cumbersome equipment. And it was ending up putting a screen between the patient and somebody else. They were doing it in the home, doing, some sort of point of care communication with the physician's office, whatever. Where are patients today in their receptivity to telehealth services in the home?
Certainly with devices that can be gotten more cheaply than, say, a very popular handheld phone, not to mention commercial devices. But, certainly something like a GrandPad or, a more intuitive type of device has been really helpful in reaching, for instance, geriatric populations. And certainly, everyone does FaceTime with their families. We've been so spread apart due to, preferences in climate or jobs or what have you. The FaceTime really has become the norm and has been used, I believe, FaceTime or Skype during the PHE as an allowed non-HIPAA compliant device, but certainly allowed to allow people that can't afford encrypted video to be used for telehealth. But getting back to the devices geared towards healthcare encounters or simple, I want to talk to my daughter, or I want to talk to my grandson or my nephew. People are very receptive of the devices. And certainly I've talked to a couple of innovators, students who want to develop things for smart TVs and have that kind of thing be integrated. I don't know if I'd want my PHI being broadcast over a smart TV, but because I think they're watching what we're watching. Certainly people just, they love it. They do love it.
So let's talk about, what's in the way of taking advantage of this innovative technologies in telehealth, because obviously it sounds to me like it's a positive advance that we've seen over some recent times, bringing a variety of values and stakeholders pretty much across the board, get some value out of it. What are the barriers that we see up there? And Dan, you specialize in policy issues, as that vice president for policy for VNSNY. What are the policy roadblocks that are there?
Well, we saw some interesting things happen during the public health emergency with the, waivers on that really expanded the use of telehealth in doctors' offices, with behavioral health. There were lots of restrictions were eased, and that was we are hoping and seeing that some of that could be made permanent. We hope it is. The one thing that was not really addressed, well, there might have been other things, but one thing that really wasn't addressed was in the home health benefit. That while there's doctors are allowed to do telehealth and nurse practitioners and behavioral health providers and hospice, the home care was really kind of like left out of the equation. And you would think that given how important care in the home was, and the issues of staffing and preventing infection, that there would be a little bit more attention paid there. And we're hopeful. Certainly, CMS made some good strides by allowing it to be included as an administrative cost. That's certainly a good thing. But the impact that I talked about earlier, where it really kind of runs up against the whole home health benefit, and if you use it too much, you risk not getting paid, even though you're providing a level of care that that is necessary for that patient. We're hoping that, and I know that there's legislation to do this, the HETS Act, which would hopefully essentially require CMS to develop a reimbursement mechanism for home care telehealth services. We think that that's a great step, and anything that will help bring home care into the 21st century and give parity alongside other healthcare providers would be very useful.
Yeah, it would seem pretty apparent that if you're not getting paid for something, if you're not getting your cost even covered, that would be a barrier to people engaging in it, embracing it even in that way. Carol, are there other barriers there? Anything from the patient side or the staff side that might be something that we can deal with to get the service more appropriately used in the home care setting?
Well, I do want to go back to the issue of health equity. Certainly what Dan was saying about assuming people have broadband, assuming they have internet connections, assuming they have all this stuff. Not everybody has the money or even the inclination to have a smartphone or to be connected, or, certainly in terms of the telehealth programs that we've been overseeing at UCSF, we now have, interpretation services have been very widely vetted and included in every telehealth encounter where it's needed. The website that we have that's patient facing has, I think, 14 languages, so that people of different backgrounds and ethnicities and, orientations can feel comfortable contacting a provider. And a lot of this, I think, is overlooked when people say, oh, everybody's just going to go for that. Well, culturally, maybe it's not appropriate for that patient to want to do that. How do we address the cultural aspects of someone wanting to participate in a telehealth visit? The language aspects, and I want to say primarily the monetary. I mean, if everybody felt secure about going on the internet within a city, within an urban area, like I probably would not log on to the free Wi-Fi in downtown San Francisco because of hackers. But if there were a healthcare network or something that could be provided by municipalities or by the federal government, that would be really cool.
You pointed out, pretty important thing to using telehealth is you have to have good, solid internet connection. And notoriously, rural areas do not have the broadband availability, but that even happens in a city. The availability of it may be overused, or it may be such that buildings block it in terms of an actual approach. And then, of course, where does the hardware come from? Is it someone's phone that they're using themselves, or is it equipment provided by the supplier of the services being presented? One question that I'd like to explore a little further too is the staff itself. Is there any special need for training of the staff to work with doing a telehealth visit, or do people just naturally take to it? Carol?
I'll answer that first, since I was like, definitely the front desk staff and the front facing staff is probably your most important entity or most important asset that you want to train and make comfortable, because their level of comfort is going to transfer to the patient. And so, from the bottom up, everyone talks about the MDs or the NPs or the PAs. But really, it's that person that's calling the patient and saying, hey, we want you to do a video visit, and this is how you log on, and do you have this equipment, and do you not? Their level of ease in speaking the language of how to do this and guiding patients through it really is essential. So training is a big deal.
Yeah. Well, I always think of telehealth as a tool rather than a service. And, invariably my mind then goes to the workshop down in the basement of my house here where I do woodworking. I don't have great skill, but I'll build furniture and I'll build other kinds of things. But I've got all these great tools, but I don't think I have the tool talent to really make full use of those kinds of tools. and I can see telehealth in a similar capacity. So we likely see as more and more adoption and use and payment for the telehealth that we're going to need to have some specialty training for the staff that are utilizing the services. Now, Dan, I want to segue over to you. You mentioned something called the HETS Act, when talking about some of the barriers of reimbursement. What is the attitude you see in Congress now towards telehealth? Is it favorable? Is it cautious or unfavorable?
I think it has to be taken into the larger context of how are we caring for vulnerable individuals, given the pandemic, given the population, in a population that's aging and getting more frail, and we have a real crisis. I mean, there's no way to around it, and I think Congress is starting to wake up to the fact that we need to put money into home-based services. That's what it's called the Better Care, Better Jobs Act is intended to do, put a lot of money into ensuring that people have access to care in the home, and that we have a workforce that's adequately compensated to provide that care. That's one step. There's another really excellent piece of legislation nicknamed Choose Home, which is essentially a piece of legislation that would allow people who would normally get their post-hospital care in a skilled nursing facility, but could be cared for in the home, except for they don't have that caregiving support, right? So this would allow a home health agency to care for that patient with the appropriate personal care services, home care services, and would probably save the system a lot of money, and would be, if the patient chose it, it's basically a patient choice initiative. So something that the patient wants, probably something that will prevent an infection from congregate care settings, altogether a really positive move towards care in the home. Care is going to happen in the home more and more. I mean, I think we have to recognize that, both from a public health standpoint and just a practical standpoint. And we have to have both the technology, the payment systems, and the staffing resources to make it happen.
Well, I think there's been a great capsulizing of some of the advocacy efforts ongoing. And for those who want to learn some more about these advocacy efforts, I'll give my own promo. Go to our website at NAHC.org, that's National Association for Home Care.org, and you can get information about Choose Home, about the HETS Act, and further information. There's another bill out there that's kind of widespread on telehealth called the Connect Act, and something you could all get engaged and help move. My pitch is always that noise matters in Washington, and noise is what you otherwise define as grassroots support. So we've only got a couple of minutes left here. So I wanted to get your kind of like 2-sentence view of what the outlook is for telehealth in the home setting, your forecast. You're out there now forecasting not the weather, but your forecast for removing some of these barriers and improving the ability to use telehealth services. Carol, what about you? Are you an optimist or a pessimist, or just very practical about things?
I'm an optimist in this respect. I am stealing a line from a presentation I saw approximately a month ago, where the presenter said, we need to approach this as caregivers and policymakers in light of the most important customers, ourselves, because one day we're going to need that home health care, and we're going to need those opportunities that maybe aren't important to us right now, but in terms of things like aging in place and moving more towards home-based care, which it seems like things are going.
Yeah, and if people adopt that viewpoint, I suspect telehealth has a pretty positive future. Dan, how about you in terms of your outlook?
Thanks, Bill. And first of all, I want to put a plug in for you and for catalyzing the advocacy and the work in Washington and the industry around these really important issues and this really important legislation. Choose Home. All right. So with that, I want to say, so I think that, first of all, it's never going to replace in-home care, nor should it. But we have to be, I think, practical and realistic that growing population, shortage of workforce to serve them. So the use of those human resources at the highest and best use is critical, and that is going to necessitate a more a progressive and functional telehealth policy and payment system. It just has to.
Well, thank you, Dan, and I want to thank you both. We've reached the end of our time here, and hopefully the audience walks away much more knowing than they were when they started. So I want to thank Dan Lowenstein from the Visiting Nurse Service of New York and Carol Yarbrough from the University of California in San Francisco. And thank you for your time listening to us today. Take care now.
Thank you.